Very good. All right, so let's move on. So today, what we're going to do, we've got a real quick, we've got 40 minutes here. We're going to do, and what we decided the format is you can only talk for 60 seconds. All right, and if you've got something to offer, raise your hand and you get the mic. 60 seconds roughly. I'm not going to be a stickler. All right, I'll be a stickler. All right, 60 seconds. You got to give your tips in 60 seconds. If you don't have anything to add, then you can pass. You can pass. So this is the MSTIC format, and then we'll have time for question and answer. Go ahead to the next slide. Here are the topics for our panelists. Go ahead next. Keep going there. Question and answer. The next one. There we go. We're going to talk about equipment, incision, capsulotomy, nuclear delivery technique, post-op issues, and tough cases. And these guys have not been prearranged, as you can tell. These they haven't really gotten, So anyhow. All right, good. All right, move on to the next slide there. Okay, so we're going to start with equipment. First one is reusing blades. Raise your hand if you got an answer on reusing blades.
Okay, so you'll have to reuse blades in most places, and if you want to do that, here's a quick tip. If you're using a blunt blade or dull blade, that blade is going to buttonhole. If your next case comes up and the nurse hands you a brand new blade, I'm talking about a crescent blade, that blade, if you're not armed and warned properly, is going to premature entry.
My main tip would be to always know what you're using. The problem is that when you're using a lot of different levels of, this has been used twice, this has been used 4 times. So what I've done is I've separated them into buckets. The new blade bucket, the used once bucket, and the used twice bucket. I usually don't need more than that. Anybody else?
So I find some blades are easy to reuse, like the Alcon blade, which is kind of it has that matte finish to it. I think the way it's finished, it's easy to reuse and will actually go 4 or 5 times. Whereas the other ones that have the shiny steel tip, you're pretty much done in 2 uses.
Agreed with all those things, especially the quality of the blade you start with determines how long you can use the blade for sure.
All right, we're going to go on to low cost viscoelastics for 10.
The better cost, the more money you can spend here, the better. But this is going to be a big eater of your budget if you're not careful. But the low-cost viscoelastics, HPMC, leave you with corneal edema the next day. You have to get it all out. You have to really irrigate that AC very well before you're done.
I just use Hypermellulose 2% from our lab. It's reasonably inexpensive. If I get it's pretty liquid. So if I get vitreous, then I might switch up to one of my more expensive viscoelastics to get the situation under control.
And again, my advice would be know what you're using. If you work in different locations, for example, or you have different suppliers, make sure your nurse tells you that you switched to a different supplier. Otherwise, you can get yourself in trouble.
Yeah. So, like you said, low-cost viscoelastic. I think Irvin, it's called Orovisc. But you have to be careful, especially in very warm environments. Most of my experience is from working in India and in the Himalayas, because you can have 2 seasons, it's bake or boil. So the viscoelastic changes, and in fact, sometimes when you inject and you expect it to come out viscous, it just comes out as liquid. Have you experienced that?
And one last tip is if you're using low-cost viscoelastics and you want to get a better outcome, just go to air. It really works when you put your IOL in.
I agree with that. Yeah.
What's the cost of that?
Maybe better.
Filtered or unfiltered.
Depends if it's using or that we're breathing or somebody else.
I got a tip for North American surgeons who'd like to do capsulotomy, and that is to do the low-cost viscoelastic through the paracentesis first and do the capsulotomy with the cystotome before, not through the main incision, and it doesn't burp out.
One more tip, and there are like 50,000 different ways to do the surgery. So I hydro dissect my nucleus with viscoelastic, and so I'm I'd say more than the average user as far as viscoelastic is concerned. And I do that to reduce the size, debulk my nucleus, because it takes up the cortex very easily, and then I have a small incision to expel my nucleus out of.
All right, we're moving on to the incision, temporal versus superior.
I will sit temporal anytime I can, unless there's more than a diopter of astigmatism that I could knock out if I sat superior, because the average old person, you're going to help their astigmatism post-op by sitting temporally. The downside is then you really need to close conj. If you sit superiorly, if the conj doesn't close super great, it's not a big deal. But I feel if I'm sitting temporally, I really have to do a real conj closure, and sometimes it's pesky.
One study that was done, it's about 5 years ago now, the superior temporal incision seems to be the least astigmatic, inducing astigmatism of the lot. So I sit temporal, I sit at the patient's head. That gives me two advantages. One, I can always operate superior temporal, which seems to be the least effect on astigmatism. The second is that the way you showed the two beds side by side, I'm not having to worry about is this a left eye or a right eye, and I can work much more efficiently if I sit at their head.
So I use a superior approach for this, and that's because I have a superior rectus parietal suture, and that gives me countertraction when I'm dissecting into my scleral bed.
You don't still use a superior rectus suture, do you?
Just for the...
Okay, let's get to that.
The prof and the student battle.
I wrote one other thing on temporal. We moved to temporal a number of years ago and haven't moved back because the visualization seems better. And second is we hinge it superiorly so that the conj will close more likely. So we make the incision down below and then along the limbus.
That's nice. I do that on half the eyes. It depends on what side of the head I'm sitting on. So that's a good tip.
All right, side port number, and where's the side ports?
I use usually one paracentesis, and I do it all the way on the other side of me. So if I'm sitting temporally, let's say at 9 o'clock, I would do it at 3 o'clock. Or if I'm sitting at 12 o'clock, I do it at 6 o'clock. If things get complicated, then I just put in another side port so I have another angle at things.
Yeah, I think that's pretty standard. But a nice way to do it for phaco surgeons going into MSEC is just to keep it easy for your right hand to go in easily if you're right-handed. So make it so it's going to be really easy for you to do your, what that'll be around about 30 degrees off from your main incision, either left or right.
And for me, it's about the ergonomics of it also, where it actually winds up. Make sure you can use it, because then if you need it in an emergency, you're comfortable to use it. The only caveat is to be aware that you're not too close to the tunnel.
Yeah, I always use two, both sides, along the horizontal.
I'm totally with AJ. I use two, and I put, to me, the side port is critical because to make it, for a phacosurgeon, doing all the IA with the Simcoe through the side port gives you a deep, safe chamber. And instead of doing it through your, so I try not to use the incision except for taking the nucleus out and for putting the lens in. Those are the only two things I use the incision for. Use the side port for everything else.
I use the main incision. When I first start taking cortex out, I reach across because you still have the posterior cortex when I'm reaching all the way across the eye, and I take that out first, and then I'll switch to my opposite side port so that I have a stable chamber when the capsule is more vulnerable.
I do the same. I think that's a good way to do it too.
All right, here comes the controversial. Why, AJ, why?
One word, always. So I think you just get good exposure, especially because tunneling is the most crucial aspect, because if you get a good tunnel that's self-sealing, that's 80% of the game won. So I like the amount of exposure I get when I get a superior rectus. And sometimes I don't even think, sometimes it happens that I don't engage the insertion of the muscle, some kind of tenons in that area that gives me countertraction. And when I have a superior rectus, one of the advantages I already discussed that I have, I'm able to dissect downwards. And the second thing is that when you have traction on it, the conjunctile wants to move away from your incision line, which helps because it increases the amount of exposure because it's being pulled on the back. And that's just the way I've been doing it. I do not use superior rectus suture for phaco.
So you apparently also like the ptosis that you get post-operatively from the superior rectus suture. That's really nice. Also, a nice touch, in case they have a little overexposure at the droopy eyelid. So I've done when I work at several places. They were using superior rectus sutures, and I did not. And their patients were lined up on one side, and mine were on the other. And I said, "What do you notice about these patients?" We were standing at the end of the hall, and they were looking. I'll look fine. Well, about half of those, their eyelids were down half-mast. That were using the superior rectus sutures. So, which is why I tried to talk you out of doing that, but apparently with no effect. So,
Thanks. But there is a case for that, Glenn. There really is. And the case for that is trainees. And so for trainees, you really must encourage them to put a superior rectus suture in, whatever it costs. And I must say, because you can see a trainee first time trying to get that rectus muscle, and it can take an awful long time. But they've got to get it in, otherwise they can't keep
John,
going.
wouldn't you say the superior rectus suture, when you're coming to express the nucleus, that is an advantage when you have a superior rectus? When we moved temporal, we didn't have a superior rectus suture. We noticed we've got to push the eye away. What we used to do with the superior rectus suture is pull on it, and that moves the eye infraductive, and you don't have that temporal.
But you're not using the hook. We're getting there.
We push in the temporal. We have to push the eye away.
Right, you're using the fish hook as well.
No.
But that's coming later, I think.
We can hardly wait, John. All right, capsulotomy.
And another advantage of it is, like you said, in trainees, where especially if you don't have a good block, and if you haven't blocked the patient, I think the superior rectus helps to stabilize the globe.
Helps to find out if the block was good, right?
Yeah. And while we're talking about superior, when you're learning, you should sit superior. It hides a lot of sin. There's no hiding of the sin temporally. If you mess up the iris, or the lid covers a lot. Yeah,
it's nice to have it.
That ptosis is helpful for that.
Yes, the ptosis. I like big ptosis. Big ptosis.
All right, moving on to capsulotomy. CCC, V capsulotomy, C. What's that one? C.
It's a variation of the V. Ben Roberts says that.
Can opener or go ahead.
Go, buddy. I got it. I trained in Nepal, and they do a V capsulotomy there, so I like it. I make my tunnel. I don't enter, but then I take a 27-gauge needle right through about the limbus, so it's halfway up my tunnel, and then I just turn the needle on its side, and I stab it in, bring it back towards myself, go to the other side, stab it in, bring it back toward myself. And you can do it blind. So if you get a lot of fluff and mature cataract and you can't see what you're doing, you can literally just cut back towards yourself, cut back to yourself, and you're good to go.
We don't like to use that word when we operate.
That's what I do. And then at the end of the case, though, the one downside is that at the end of the case, then you have to amputate the flap after you put the IOL in, and sometimes that's annoying. It gets caught up under the iris, and you have to go search around for it, and that can be annoying. I do like, if you have a complicated case, those nice edges of the capsule really help you see if you're in the bag, or if you want to put a sulcus lens in, gives you a really nice visualization of what you're doing. So I really like it.
Well, one of the last COSs that I worked at, I think you gave us those 3D glasses. Do you remember that, Glenn? At Hilton Head, we all sat there and we all said, wow. And it was very cool that time. Thanks, Stan, for putting that together. I'll never forget that. But what I learned there was that I changed my practice after that 3D experience, was that the can opener, really, if you're training trainees, you've got to go to can opener, because that's the safest. It makes lots of little incisions, much less chance of any one of them tearing out to the back.
So I'll do a CCC, and I'll make 4 radial incisions just to open the anterior capsular flap, so it's easier for me to dial my nucleus out. And like you said, in case I get into trouble, I always have a rim to put my sulcus lens.
See, that's great. I can harass you again. See, so actually you do a can opener wannabe. Is what you do. Is that what you're saying? So you go to all the trouble of doing capsule X, and then you do a can opener.
And then if it fails, I can always go.
See, it's perfect. I just love that. Sorry, I just had to.
Anyone else? I have a tip for phacosurgeons, and when I take a phacosurgeon with me, I say, practice your capsulotomy, your CCC, with the cystotome at home, and do that at home. And the only difference, we're going to make them large. And if you make a large and then we've got trypan blue, so we use trypan blue, and it's safe as long as you make it large. But if it's not large, you need to make the cuts, not to. But if you can make a 7-8 millimeter CCC, anything will come out of that.
That's the risk with CCC, is that we're not used to making them that large. So I think so that's the increased risk. You're trying to make it larger than you usually make it, and you're right there at that edge, right where the zonular insertions is, and the chance for run out is a little.
We'll use a microscope there, Glenn.
Well, that makes it different.
I feel like you put a lot more stress on the zonule too. When that CCC isn't quite big enough, if you try to go with it, you can really stress the zonule. And there's a lot of little pupils out there and out there too. And these other capsulotomy, like I said, you can do them blind, so you don't have to see the whole capsule. You can stick your needle out under the iris and saw it back towards yourself.
You can do a can opener blind also.
Yeah.
Well, who's guilty of dropped nuclei doing phacosurgery? Yes, me. Who's guilty of a dropped nucleus with scleral tunnel or MSIC? It's really only if you're going to do a CCC. That's going to be, you're putting yourself into the phaco territory of dropped nucleus. The only dropped nucleus I've ever had in MSIC is with a CCC. And so it's kind of scared me a little bit. I think because I made them too small. I didn't do the 8 millimeters.
Well, and to me, the other difference with the capsulotomy technique is the fast guys never do a CCC in trypan blue. That adds minutes to your time. If you're doing a 3-minute case, it's likely you're doing a fish hook, and I mean, you cut steps. And one way you cut steps is don't put in trypan blue, do a V capsulotomy, do it with your eyes closed. Quick. All right, we got nuclear delivery, ways to express your lens, loop, Simcoe, visco expression.
I'm a lens loop guy myself.
Dry.
Yeah, he's in the big league. So dry. I do a hydro expression or a visco expression. If the nucleus is small enough and soft, it'll come with the viscoelastic.
So, don't just say what you use, but what goes along with getting the nucleus out with your lens loop dry. I mean, that makes it too easy, Glenn. Tell us the other tricks. Well, we want to teach the tips.
Tips.
Yeah.
So to me, the big tip with the lens loop delivery is that you're not actually you're actually only supporting the nucleus and opening the tunnel, providing a pathway for it to leave the anterior chamber. You're not lifting it, you're not dragging it, you're not doing any of those things. It's just providing an opening to so that the nucleus can glide out, so that you reduce any risk for endothelial contact, but at the same time you're protecting the posterior capsule with the lens loop.
So what's the secret of why is it coming out? If you got
Because you're pushing back against so to get this to work, you just stabilize the eye, and then a little pressure on the inner tunnel wall, the back side of the tunnel, a little pressure on the inner tunnel wall, and then just allow things to just glide out, so it doesn't require a lot of force to do that. If you have the adequate size tunnel.
Eye pushed away?
Doesn't, no.
Didn't.
No. So eye centered but stabilized. Lens loop under the nucleus, little pressure posterior, and just and kind of glide out with you.
No secret magnets or anything?
No secret magnets, no secret decoder ring, no.
Glenn, why do you prefer dry over using hydrostatic pressure? So when you open the tunnel, you have hydrostatic pressure pushing it out of the eye for you.
Yeah, that's
more.
a nice way. To me, it
doesn't matter.
It's time.
Okay.
And it doesn't seem to matter. I
Okay.
mean, it doesn't make any difference in my hands. Corneas
Yeah.
look real good afterwards.
Is that a 12 millimeter incision?
No, this is 7 by 8 by 4.
Okay.
So 7, 8, and then about 4 on the side.
Okay. Anyone else?
I use a Simcoe cannula. I'm using it already. It's irrigating. It gives me hydrostatic pressure. I like to turn the eye away from me. So if I have the rectus suture, I'll put a little traction again on the suture. If not, or always, I'll take my tooth forceps, grab sclera posteriorly, rotate the eye away from me. Then I visualize my Simcoe going in the eye. I want to see the tip over iris. I take it out peripherally over iris. I see the tip over iris. The lens is above the Simcoe. I want to see my tip on the other side above the iris. And then I push down. And then the water pushes the lens out as I retract my Simcoe. Like Glenn said, this isn't a hook and pull. This is I burp my wound open and the fluid pulls everything out. And if you do that, then you don't hurt the iris. You protect the iris in the bag from the Simcoe, and the water just pushes the lens out. And it's like delivering a baby. Your wound might be a little tight. If you just sit there and wait for it, the lens will kind of slowly. If it's really tight, sometimes you have to stop.
Do a episiotomy?
Sometimes you have to do an episiotomy. But if you wait for it, sometimes you don't have to enlarge your wound. It'll kind of just slowly work its way out like a baby.
Okay, guys, I want to go back. We forgot. You have something on that? On your fish hook? Yeah, sorry, go ahead.
Well, I've tried all these guys' techniques, and they all look very good. But you know what looks best on TV is the fish hook. I must tell you, the fish hook is just such an easy technique, and it looks so terrible, and it just looks like, don't do that, don't do that. But it works every time. It's got low volume going into the eye. You just drag it out, and it's got a good outcome.
Gotta give you a hard time too. Okay, so Bidya Pant in Nepal, like this incredible, 60,000 cases a year sort of guy, like has the record for shortest cataracts are like a minute and a half or something like this. This incredible surgeon, he does the fish hook. So I got him to come and we compared side by side, lens loop guy, fish hook guy. Bidya was the fish hook guy. And the lens loop guy's corneas looked better the first day. They actually did. So doesn't mean it shouldn't do that. I'm just saying though that there's no, to me the highest priority is that you got a good clear cornea the first day. And the disadvantage that I had in discussion with, by the way, he still does fish hook, of course. That didn't change his mind one lick.
Once a fish hook,
always a fish hook. So, it was he talks about delivering it into the tunnel as the first step. The problem was that when you put the fish hook in, I think in our discussion he agreed, when you put the fish hook in, it actually dislodges the nucleus slightly, and apparently it's enough to cause some trauma to the corneal endothelium. So it's just interesting. I just did that in India just this last 6 months ago. So it's interesting.
So I just wanted to add to what Dr. Strauss said. Another feature that, since you were asking that, and I've seen him do this, and we did, and I've seen you use that in Africa. The lens loop is actually it's like a spoon. So the nucleus kind of just sits in that little cavity. So when you come out, you're just pulling everything out. And when you're hydroexpressing, I agree. Once the nucleus engages the tunnel, or even if a little bit comes out, sometimes I'll take a 26 gauge needle, impale that tip, and just pull the rest out. But one of the things you have to be careful while doing a hydroexpression, which is what I do, is if you have anything in its way, like cortical material or something, it's not going to come. So in my experience, you've got to clear the passage for it and then press the posterior lip. And I use a cyclodialysis spatula for that, or an iris repositor, and then just let it come out.
Jana, would you say that the fish hook is a good technique for a beginner to start with, or is that not a good starting technique?
I think the Simcoe is probably, or the loop is definitely better for a beginner. Yeah, I wouldn't go straight to fish hook. Although I've trained so many people in the fish hook, I'm not sure that I'm actually believe what I say. What do you think, Glenn?
Personally, I would say the lens loop is a good starting.
Yeah, I think so.
When you don't have to learn with the fish hook, you make your own fish hooks, and it's always a little tricky. And then it's slow. You kind of breaks the rhythm of the case a bit, or if you bend it before the case and you don't bend it quite right. I mean, there's as a trainee that's just learning to do this, and I've just had trouble.
You bend one every time, or do you? No, okay.
No, you can have
pre-bent.
Yeah.
Okay.
So just kind of, I don't know. For trainees, I prefer the lens loop.
These haven't been used in the lake fishing. No.
Well, you don't like the barbs there. You could have found them all.
Okay. Yeah. I want to move back. So we got the nucleus into the anterior chamber, but we didn't hear how you guys get it into the anterior chamber. Let's talk about that for less than 2 minutes.
When I was learning M6, I thought that was the most challenging step of the whole thing was getting that doggone lens into the AC. A hydrodissection, obviously hydrodissection is very important. Hydrodissection before you start manipulating the lens. But I just take a cannula. I usually, at that point, I have fluid, and I just jab it in at the near side through my main incision and push down, and then start rotating and pop it up on the opposite side. Then I take my cannula back to the side it's popped up on. Just kind of rotate it around and pop the other side up.
Kind of a sweep and inject.
Yeah, and if I'm having trouble, if I have trouble while I'm doing that, I like to put a little viscoelastic anyways between my when I get into the AC. I like to put a little viscoelastic between the lens and the cornea before I pull it out. So if I'm having trouble, I switch to my viscoelastic and use the cannula. It's a little bit bigger usually, and a little gentler, and I can be more aggressive with the viscoelastic.
Yeah, I think that's important as a good points. And I think for students, you need to have a progression. That's the most gentle way to get to dislocate the nucleus. But then the next step up is perhaps to use a visco behind it if you can't do that. Or if you're really having trouble, a Simcoe will help you hugely, just to if you can sweep that round the one side and just pop it up.
Yeah.
Well, to make a case for fishhooks again, you don't have to dislocate the nucleus every time.
You can just take out the bag with the lens.
So this is a difficult step, and I've noticed this actually sometimes depends on the degree of cataract. The ones that are brown and black, you can just rock them out, and while you have them impaled, you can just go back, forth, and out they come. I think a good step to do this is that hydrodissection. So if it tilts and one edge of it comes up above the level of the anterior capsular flap, then I know that it's going to be easy, because then I usually like to take a Sinskey and then I start rolling from that edge. If you start rotating it, it kind of dials itself out, and just to make sure that it's definitely out, once I have a substantial part of it above the capsule, I'll inject some viscoelastic behind the lens, then I know I'm safe.
Yeah, and one thing that you guys didn't mention, although you mentioned it earlier, but if you're having trouble getting it out, you may not have a big enough capsular excess, or you may need to add more cuts. Don't risk it.
Should have done a can opener.
Should have done a can opener. That's right. All right, moving on. All right, anybody have experience with air as an AC maintainer? Jana, you want to start with that one?
Well, this goes back to our question about the use of viscoelastics, and yeah, this one you can use air. You have to keep topping it up. It's particularly useful when you're inserting an IOL. However, I will say in younger patients it's not useful because the sclera is too elastic. It's only really good for deep chambers or chambers where your wound is very stable, and often that tends to be elderly people. But there again, this is a great advantage. If you've got someone who's got a really unstable cornea, I'd encourage you to try using air, and a very elderly person to maintain that anterior chamber. Get your lens in and then just remove your air at the end. It's much quicker and puts much less pressure on the endothelium.
Anybody with Blumenthal AC maintainer experience?
The anterior chamber maintainer, in other words, connected to your irrigation bottle and then plugged into the anterior chamber. That approach, the Blumenthal technique. I did that for a while, thinking that made sense. But the extra time and the fact that it was more about the tunnel than the maintainer. The depth of the chamber was more about how I managed the tunnel. In other words, if I didn't manage the tunnel, I don't care how fast you're running the fluid into the eye with the maintainer. It just didn't.
What about using that when you got a 20/80 cataract that's a good phaco candidate, and it's a 2+ nuclear sclerosis, and you know you're getting a lot of cortical cleanup? Isn't that going to be a lot easier to take your, what do we call that thing, Dave? Just the single port thing. You got your AC maintainer in, and it makes your IA cleanup so much quicker than a Simcoe. When you've got that AC maintainer, make you feel at home.
Yeah, that's true. For me, when I have a lot of residual cortex, so it's not as dense a nucleosclerotic, or maybe it's a PSC cataract or whatever, then I use the side port, just like you talked about with your Simcoe. And I get a good, the chamber is maintained very nicely that way. You guys?
I don't use it.
I think it's a good thing to use when you're in trouble, but it's a bit of a luxury.
Yep. The first time I used it, I put the irrigating fluid right through the zonules. I had a nice zonular dialysis, so it was the last time I used it as well. Not a great experience.
Do you use a Lewicki?
No, the other thing that we learned from Dr. Dirks and Udo, who's an expert with that, is the lumen size on that is critical. There are bad AC maintainers and there are good AC maintainers, and we didn't realize that. The lumen size has to be big enough that you get a good enough flow through the thing. So that's one tip that we've learned on that. But we'll move on. Local anesthetic technique.
Right now, we're just doing retrobulbar. But interested in less invasive anesthesia. Is anyone doing subtenons?
Well, we did, must have done about 6,000 retrobulbars, but by the third resuscitation that I had to do, I just said no more. That's it. So by the third time you had to resuscitate someone, admittedly the retrobulbars were placed by a nurse. We're using lidocaine with a little bit of Ydase, plus a little bit of Marcaine. And 1,000 cases you find, but it's that one case that just gets you. And it just stressed me out so much, grabbing people back from the precipice, that we went instantly to subtenons. And fortunately, I had a British resident with me, and the British are big on subtenons. And let me try and tell you all, please change to subtenons as soon as you can. It's such an easy technique. You do it on the table, right there with the patient. You don't have to do it outside. It's done by you. It takes 2 minutes. You don't need any monitoring. I guess maybe you should, but there's absolutely no need. It's like the same as any other little bit of anesthetic under your skin. And only problem. Okay. Well, you make a little incision. You'd have to pick up the conj and the tenons in the inframedial side, round about, inframedial, about 4 or 5 millimeters back from the cornea sclera. Lift that up with one incision, make a little cut down with your conj scissors onto the sclera, and then spread underneath what you've just lifted up, and you'll see like a little hole opening up down into the back of the eye there.
Your anesthetic for that is
topical.
Just which topical?
Novocine or tetracaine, whatever you've got. And the person, by the way, must look up. That's the challenge, because elderly and infirm, and they might look all over. He's laughing because we're laughing about the same patients. So if you can get them to look up and you can make that little incision, you need to get hold of a subtenons cannula. Nothing else will really do. It's blunt-ended. I've seen it done, and I've done it once or twice with a normal Jalco or IV, but it's not the same. And you just stick that in behind, and you just give them 3 mils of lignocaine.
How far back?
As far back as that needle will go. It just slides in very easily, and it's a bit of pressure, and then suddenly it goes in. It's the equivalent of if I mean, I did anesthetics, and I did a residency in anesthetics. It's equivalent of changing from a spinal anesthetic to an epidural.
Just one quick note: if you don't do that, at the least, I would change to a peribulbar. So I would stay away from retrobulbar for exactly. But I've done a little over 10,000 cases with peribulbar blocks, topped up if needed with the subtenons using the 25 gauge cannula from my viscoelastic, basically, and have had one.
So I agree with everything you said about the subtenons. All the M6 I've done is under peribulbar, but I do use it for my vitrectomy cases, and it's crucial that you get below the tenons, because everything looks the same, the sclera and Nick. Exactly. It's just a different space, and it acts a lot faster. And I use a Bishop Harmon cannula, which is a blunt cannula. And the trick is to make sure you've gotten under the tenons, because if you haven't, your anesthetic's going to just cause the tenons to swell up, and it's going to look really messy, and it's not going to do its job. But it's a great way to get the eye immobile and
You get
it's
a
very
good ophthalmoplegia with that.
very good.
Sorry, I forgot to say, if you're new to MSIC, don't do a subtenons. You've got very little ophthalmoplegia. You've got a person's eye still wanders around. It's not easy. So please only go there if you've done several hundred, and then it's worthwhile you trying that. You don't have a stable eye, a stable platform. That eye's going to move.
We forgot to say that fine print.
That's the fine print.
All right, moving on quickly. 6 in children. M6 in children.
What do you mean by
I don't know. One of you guys wrote the topic.
Well, I'm just asking, has anyone got experience? Because in a youngster, it's a little bit different doing MSIC in a child. The tissues are different. The tunnel is not really as stable, and you will be needing a lot of visco, and you might be needing an AC maintainer. So you should plan ahead for that.
The nice thing is you can make the tunnel a lot smaller, but I try to I do more of a phaco technique if I have kids.
There's no expression, right? You're Simcoe and going in and sucking the lens out, right?
I don't find it's that easy, actually. I mean, if I'm talking kids down to maybe 11, 12 years old is what I don't know what children you're talking about, but younger than 12, it's very difficult to deal with. Between 12 and 15 years old, if you could do a small tunnel, like you said, but even then, I find it a little difficult to just suck out the nucleus. It's a little too formed.
I don't do it. I've seen it in Nepal. They did it.
Oh,
It's literally because they don't have to use a foldable lens.
they can do anything in Nepal.
What about a 2-year-old?
Amazing.
What about a 2-year-old, Glenn? Anything different?
In a 2-year-old, I don't do what I would really call SICS. It's a INA with a pars plana vitrectomy and a posterior capsulotomy.
I think this is important. This is useful to know how to do, because you may not have a soft IOL to use, and you might be putting in one of your cheaper soft hard IOLs, and you do need to have a bigger capsule, a bigger wound. But just to let you know that you can get away without sutures in a child. You don't have to suture a child if you've made your tunnel long enough or far enough away from the limbs.
Moving right on to suturing posterior
Very quickly.
Yep, George, you've got a question.
Put the lens before or after posterior capsulotomy?
I put the lens in first, and then I do a pars plana capsulotomy after.
Same for me. Lens first.
Very little experience in children.
You're the red one.
Well, I think you don't have a problem of the nucleus. The nucleus should be aspiratable, unless, of course, it's made a plate, but that's usually quite fragile. You can usually fragment that. But I would say you're probably looking at a 5 millimeter tunnel, about that sort of size. Enough for your haptic to go through, for your optic to go through. And depending what size optic you've got available in your hard lens, you get 5.5 or 6 millimeter optic, so that's the size you're going to use.
I've got a number of children this year that were 2 years old, roughly, and actually was a little nervous putting the lens in and not doing pars plana. So I just did the vitrectomy, posterior capsulotomy, kept it relatively small, maybe 4 or 5 millimeters posterior capsulotomy size. Did the antivitrectomy, then put the lens in after, and that went fine. No major issues. Just watch where your haptic went, so it didn't snag the posterior capsule. But it was a smaller posterior capsular opening, big enough that I didn't think it's going to re-scar.
There's one the only other thing I would add is that I've gotten to the point where I will not use a PMMA lens in a child. I'll only use an acrylic foldable myself. So that means I use a tunnel that's 3.5 by 3.5. It's almost a square. In fact, it is a square. And I straddle the limbus with that. And when I do that, I don't need suture, just like you described. But I don't use a PMMA lens in a child anymore.
And, Dr. Strauss and I was just talking about this over lunch. Anyone who's doing surgery on children, cataract surgery on children outside the United States, you must look at the most recent outcome of the infantile aphakia study. And there's some numbers that everyone should look at.
I agree. The issue is in a lot of these places, it's nearly impossible to get a contact lens for these kids, these aphakic kids. So I think in lots of the developing world, contact lens isn't an option for a lot of us. And so you're kind of forced into the IOL. Meaning it's better to leave them aphakic uncorrected than to put in an IOL.
Well, we all have to kind of think what those numbers mean for us.
Give him the microphone there, John.
We all kind of have to decide what the numbers mean for us. And are there any pediatric ophthalmologists here? Martha, what do you think? Did you see those numbers?
Yeah, we saw the numbers. Most people, I mean, where I just
Exactly. So you took those. So you took lenses out much later.
Right. So we didn't get these kids until the Missouri screening caught them in kindergarten, and they went from one kid went from 2250, and my post-op day one he was 2080.
Wow.
So he was great, but that's because he was bilateral.
Yeah.
So I would argue, I mean, if you don't know if you're going to follow this kid up, do you put a lens in? Your risk of glaucoma is there, but to me, if you know that they're not going to follow up, then you put a lens in because that gives the child some chance.
So I think this study gives us room for thought. And like you said, are we exposing these children to the risks of glaucoma and aphakic glaucoma and not having their vision get better at age 5, age 6? So that's what we were just talking about. I think we all need to go back and rethink this whole thing, especially for many of us who don't have long-term follow-up, because that's just something we cannot have on this patient population.
All right, let's move real quickly. Suturing posterior vitreous loss. Someone's had some.
I brought that one up, Stan. I don't know if it's your guys' experience. If I've had significant vitreous loss, maybe you guys don't get vitreous loss. I find my wound, that's when I usually think about putting a suture, but I find that my wound acts very differently after I've lost vitreous, and that sometimes suturing it can be quite challenging after I've lost vitreous, and it almost feels better without a suture. Have you guys have any experience with it?
Yeah, I have something that I've found that works really nicely for that, actually, because of course the problem with these tunnels is that they're pressure maintained, and once you debulk the vitreous come out, you debulk the eye. Now the pressure is 0 or -5 or something like that, so the cornea collapses. The inner tunnel wall is very floppy, so it falls back. So, being the smart surgeon that I am, I think, well, what if I can lift that inner tunnel wall up and support it? And while I'm doing that with one hand, I'm injecting fluid with the other hand, and what that does by supporting the inner tunnel wall, by holding the posterior lip in the center, right? It has to be right in the center of your, where the groove, where the opening is. Hold it right in the center and lift up, not out, not over, but just straight up. That gives support for that inner tunnel wall. Then you inject fluid, and you'll see it almost snap. You'll see it snap into place. And once it snaps into place, now you have a chance to maintain the thing and put the suture in that you might need. You may not even need a suture, actually. Once you may find that it actually is stable once you've got a pressure to maintain it.
Yeah, I find it particularly like in Marfan's, if you're going to remove the lens and do an aggressive anterior vitrectomy, it's those people where that wound can be really annoying to me. Yeah, yeah.
You're doing a Marfan's, for example.
Yeah,
sometimes it'll be
it's
easier
a-
patient, it'll be more floppy.
Yeah, I've had a few challenges with that, so I was looking for tips.
So I found that the wound will behave differently if you have vitreous come into the wound. It's just that you can't see it. So I use Triesence, dilute Kenalog in some form, and then amputate that vitreous. Or I will use the light pipe trick, but that's just because I have a little. Yeah, have you tried that, the light pipe trick? Where if the room is completely dark and you have an endo illuminator, and you can get these boxes for like $500 that just make the light source, and if you hold the light pipe at the edge of the cornea, because of internal reflection, the whole anterior chamber lights up under your microscope, and you can very clearly see where you still have vitreous. You can actually see the whole anterior haloid face or parts of it coming. And then once I've cleaned all that out, I know that the lens and the wound's going to stay where I want it to.
Very nice. All right, moving quickly. Other uses of the M6 wound. Talking about for phacosurgeons, apparently using AC lens, sutured IOLs.
Yeah, I found the M6 wound useful for all sorts of other surgeries. I don't know if you guys have found the same.
So I routinely use, and one of my colleagues is here, Abe, Dr. White, and he and I discuss this time and time again. Most of my work is posterior segment, and the patients that I get, the ones who've had traumatic dislocation of their crystalline lens, or if they've had a sutured lens that's now floating in the mid-vitreous, I always make a scleral tunnel. I just don't enter it till I'm done with everything, and then I make a small entry with a keratome, bring it into the AC, and then enlarge my wound only when I'm ready to get it out. And I've had such good results that I can actually go back to my vitrectomy without even putting a suture. But I will put in a suture once I put in an ACIOL. So I routinely use a sclerocorneal tunnel on all my ACIOLs or lens removals, because that's just a more stable wound, rather than give him 5 sutures of the cornea.
You are a true retinal surgeon. It's like Dr. Patelli does it all, so that's great. All right, M6 trab experience combined.
I don't do it.
Here's the bad thing: when you get so used to M6 and you get a trab on the table, you just whip out an M6 and you just messed up your trab, because they look so similar when you start, don't they? And I've done that once or twice. The combination is tempting because you're right there. It is the imperative is that it's a low-cost procedure now because you're doing 2 in 1. The experience is not very clear, and not anyone's got experience, but I'd like to know more about it, and perhaps it's worth researching.
Isn't that worthwhile going temporal on your M6 so you can save your superior if you need to do a trab later?
Oh, very definitely.
Yeah, anyone with glaucoma, I do temporal no matter what their Ks are.
Moving into post-op care, intracameral antibiotics, subconj drops.
I feel pretty strongly about intracameral antibiotics myself in some of the studies and so on, and in several of the places where I've consulted with them about results that they were getting, outcomes where they had a fairly significant incidence of postoperative endophthalmitis. The single factor that changed the whole trend was switching to an intracameral 1 milligram of vancomycin or 1 milligram of cefuroxime, either one.
With post-op drops too?
Yeah, they do use post-op drops, but honestly, I bet that doesn't really matter. I think it's the injection on the table of the broad-spectrum antibiotic. So personally, I feel pretty strongly about that. I don't know if you guys do or not.
In my 2 years at Tenwick, we never used it, and I think we had 1 case of questionable endophthalmitis. We just used subconj dex gent at the end, which honestly the gent doesn't make a whole lot of sense to me, but it seems to work whatever it's doing. But so I was curious what everyone else was doing.
I think the European study which they did was enormous. Encompassed something like 15 different sites. They got, I don't know how many patients, was it 100,000, 200,000? So for me, it's fairly formidable evidence, and we've been using cefuroxime since that study came out, and we haven't had a case of endophthalmitis since.
I think if you had vitreous loss or anything abnormal happen, I would always most definitely inject intracameral. That's a given.
I was uncomfortable in Ecuador. Most Ecuadorians don't change the phaco tip or anything between cases. And so I was consulting with my, the person I consult was David Chang, and he said, well, I'd change the sleeve and the needle and just put in post intracameral Vigamox is what we end up using. Yeah.
Stan, that doesn't help HIV virus. Vigamox, sorry, doesn't do anything for HIV. So I think I'd be pretty careful about that in our context, or hepatitis.
And that's a good thing about small incision that you just get a new set of blades every time, or at least 3 steps.
All right, we got a couple more caps.
There's some questions in the back.
I'm sorry. Sorry, go ahead, Andy.
Yes, I think everyone uses drops post-op as well.
We have an audience member here shaking no that he doesn't. He's been doing this recently in the U.S. But go ahead. Who's the next question?
Do you all mix your own intracameral antibiotics, or do you have a reliable pharmacist around?
Repeat the question.
Yeah, so do we mix our own, if we're using intracameral, do we mix our own, or do we have someone that we can trust to do that? Ideally, I've trained, eventually I've got a team that's consistent and that can do it. And I always, though, part of my morning routine when I go in the room, because it's mixed for the day, of course, is I said, run through with me what you did. And it's, I know they know what they're doing, but it's just a double check. It's sort of the checklist approach to things. And there's been at least once that we caught something. We're glad that, we didn't put in 10 milligrams instead of 1 type thing.
So I've also found that certain centers will put a drop of betadine when they're done in the eye once they've repositioned conjunctiva on the incision. And that's a game changer, I think, because 9 out of 10 times your infection is going to be from your own conjunctival sac.
Great point.
All right, looks like we're moving on to posterior capsuloplasty after M6. I'm not sure what the question is. If it is, do you get it, or how do you deal with it?
We don't like it.
You don't like it?
What are your rates, do you think, with your follow-up, Jono?
I think the rates are lower than with phaco, and I don't know why. Can anyone else explain? Glenn? It's just that you don't see the rate. Perhaps our patients are a different patient select group. Perhaps it's later on in life, but I find we have very low rates of PCO.
How do you manage the PCO after? Do you have a YAG, or do you do
We have a 1980s laser. It needs a restart after each ping, so it's a very slow process.
That's dedication. Yes.
All right, and we got a question about post-op care in limited access areas. Is 1 to 2 days enough?
This was actually my question, because there's oftentimes we're faced with this dilemma. If you come in for a short-term trip, or and even in places where you're there for the long haul, the patients have a significant burden to get to you from wherever they've come from in a lot of cases. And so, what should we expect? What should we require of them? Is it enough that we would say, sorry, we're not going to do your surgery if you can't come back in 4 weeks? Just where do we draw the line in terms of what we should expect of our patients? For me, I'm happy if I get about 60% of my patients returning for a 4-week post-op, and that's horrible for here. We would never do that here. But for me, and I'm just being real honest, surely there are better ways to do this. But in the limited access areas, at least where I spend most of my time, getting patients to come back is a serious problem. And so I'm very happy. It's the reason I've really focused all my efforts on the 1-day post-op. If they've got a great look on the first day, if their cornea is clear, it's why I spend so much effort. When I train surgeons, I'm telling them it's all about how it looks on the first day. Because once I've got a good 1-day post-op, good acuity, good clear cornea, minimal inflammation, conju's well covered, the odds are very good that 4 weeks from now it's going to be excellent. But there's no guarantee. So what do you guys do?
I guess it's a little, maybe when you're doing the mobile missions, it's more of an issue. I find that rebound inflammation is a great motivator to come back. So if they're having a problem, they come back usually, I think.
How about routine?
Routine, I discharge them day one to go home, have them come back the next week at the end of the week, so it's anywhere from 7 to 10 days. Their first bottle of medicine is usually running out about that time. I give them another bottle of steroid and then send them back and tell them to come back in a month after that.
How often do they come back?
Pretty regularly.
Pretty regular.
Yeah.
Be interested in knowing.
I actually count that number. What percentage comes back? The average follow-up, and I just count how many days follow-up, is something like 10 days for all my patients. That's the average length of follow-up. So most patients don't come back. I think I need to say something about the patients that are kept in hospital for a long time. And I'm not sure if any hospitals are still doing that post-MSIC. But let me say most of it's vanity to get the visual acuity to improve really good, make your stats and your figures look nice. It's not necessary. First day one post-op is a good day to discharge. I agree with you.
All right, guys, our audience is getting a little bit antsy, so we're going to just do 30 seconds on these last. If we can get this, I don't know what happened. Yeah, go ahead.
No, I don't do anything different with keloids. I haven't.
All right. Not sure what happened, but anyhow, so what would you do with those? How would you approach that in 30 seconds?
That's great M6 case. In my opinion, that's a quick one. There's no cortex. The whole thing comes out as an intercap.
I would, depending on my setting, if I was at Tenway, I'd just do pars plana lensectomy, and that'll probably aspirate out. Usually they're young kids, and they just eat the capsule, and then do a sclerofixated IOL.
I don't know how to get, I'm not a Mac guy.
I wouldn't do M6.
How do your sclerofixated patients do? I think you've only been there for 3 years, but in Tenway, did that tenoproline break in 10 years? Because I see a lot of that.
I didn't see it break yet, but I was beginning to do the sutureless sclerofixated tunnel like Dr. Agarwal does, and it's really nice.
Do you glue it on?
No, I didn't have glue. You don't need glue. You don't need glue.
So you use a 3-piece?
Yeah, you need to use a 3-piece. You can unfold it in the eye using MST forceps. Then you can work it into the tunnels. It's really slick.
Yeah, I've tried it, but my haptics has come out. I have a success rate of 25%.
In the mic, please. So intracap, the answer is intracap, antivitrectomy, glued lens, is that what you said? Or AC lens? Sclerofixated.
I would personally use an anterior chamber lens. They're so good
To the
these
mic.
days. Anterior chamber lenses are very good these days. If you got a good multiflex type lens. In a kid, right? Yeah, so the Marfans that I've done, I have several cases I've recorded of Marfans, and they were all in their 20s. So I put in anterior chamber lenses.
Okay. Last slide here, just what would you do with this case here? You guys can turn the lights down just a little bit if you want. 2 cases, 1 case?
One case for me.
1 case? Go ahead, Jono. 30 seconds.
No, I think you should do one. I would do 1 case here because if you have it in 2 cases, if the second time round, that pterygium might be back or the patient won't be back. One of the two.
Okay. Any other questions from the audience? We didn't answer. Tried to get a good. Okay, real quick. How long's your cases, Jono? Get the microphone.
A quick one.
How's your average case?
6 to 8 minutes.
We're gonna find out who our guru is here. All right, John.
Mine right now, I'm in Burundi. I have no anterior vitrectomy. I hadn't done surgery in 2.5 years, so right now mine are 15 to 20 minutes, assuming I have no problems.
4.5 minutes.
About 18 to 20 minutes.
Very good. Good. Well, we want to thank our panel. And thank you guys for being very patient. For those that want to meet in this room, I think CEN is meeting with candidates that want to talk about issues or contracts or anything like that. You can hang around. Otherwise, go enjoy with your family this afternoon, and thank you for this day.